people could remain in work even when they had limiting conditions. She then became, after that review, the principal of Newham College, Cambridge, and in between did a number of other reviews, I think 4 in total, Carol, am I right in saying? And most recently, she has completed a review on drugs and alcohol misuse. But it's a great pleasure to welcome Carol. And Carol, thank you very much for agreeing to give our Thomas Ashton Institute lecture today. Thank you. Yes, I think so.
Thank you. Can you hear me without this, or is it better with this? With. Thank you. Well, look, thank you for that extremely kind introduction. I really feel quite honoured to be asked to do this. You're the experts. I've, over many years, had a real interest in the area, but I don't have the depth of professional knowledge of most people in this room. But I will do my very best to think about what is the state of health and well-being and work now, post-pandemic. And I think to do that, we've got to go back to what was expected of us, if you like. What was we hoping for to know whether or not we're anywhere near it, or what has actually happened. So I'd like to start with the small government review. It was a very nice, slim document. The Government Health and Work Vision of 2005. I think, Andrew, that was the year you had published your HSE management standards, which were extremely useful. And I don't think any of us could really disagree with what they wrote there. So the idea that health, that is general health and well-being at working age, is given the attention it deserves. So our general health and our well-being at an age when we might be in the workplace. And this idea that work could be beneficial, obviously that had to be good work. And importantly there, that healthcare promotes a return to work. At the time, if you recall, when they wrote this, we had had a lot of investment in the health service. So in fact, we had a more robust health service, and indeed it could respond rather faster than it can today. Work promoting our overall health and well-being, and very importantly, that we could try and get more people with disabilities and health conditions enabled to stay in work, or indeed go back to work. And people making the right lifestyle choices from an early age. So it went back as far as thinking about school children and young people. And this is what it said, that it should be at the national level, local levels, this bringing together of employers, trade unions, individuals, professionals, voluntary bodies, and other stakeholders to deliver this, which I do think actually happened over several years, with determination and long-term commitment. And one of the points I'm going to be making, it is so difficult to retain that long-term commitment at a time when, of course, politicians change, governments change, funding streams change. But there was this real intention for us to all come together to try and make this happen. I was lucky enough to become the National Director for Health and Work. I'd become very interested in occupational health while I was President of the College of Physicians. It was one of my faculties, and I realized to my shame I knew little about occupational health when I became President, and in fact I hadn't been a very good hospital doctor as far as occupational health was concerned. Was a bit late to discover it. And then I want you really to just look at the things they said that success should lead to. And maybe I can ask you now, but you can think about it throughout the lecture, have we delivered on any of those with any consistency? And well, I'll wait to the end to give you my view on that. But again, all of those things were perfectly reasonable things for us to hope to deliver. So one of the first things I did as National Director for Health and Work was to write this review, which I do think was a useful review. It aimed to be a baseline for the health of Britain's working age population. So what was our state of health? Was it good enough to enable us to be in work, to stay in work? And what could be the role, for example, of professional colleagues to maintain that health, improve it, or indeed for employers to play a bigger part, not pleading with them that that was the right thing to do. We tried very hard in that report to make the business case, because in the end it was going to be the finance director who was going to decide whether money was given to this really important issue. After all, there's a level of health below which if you fall mentally or physically, you simply cannot be at work. I mean, I'm sure we would all recognise that. And so really at the heart of that review, there was a recognition and a concern to remedy those things that impaired health, but particularly in relationship to working life. And I tried to identify factors that stood in the way and to offer interventions. And those interventions were partly a change in attitude, a need to change workplace culture, particular change in the behaviour of my own profession. Medics, the sick note was given out all too easily with no attempt to enable people to have the help that would enable them to go back to work. And then practices needed to change, and services that we needed to offer needed to change. I also, when I think where we are today, I went back to my report just to see what I'd said about chronic illness, and you'll see the reason for that a bit later on. And had I made very much reference to early life and to children? I did write a chapter on children. But the interesting thing, and these are quotes taken from the report, the employment rate at that time, this is 2007-8, of those with a health condition was rising. It was slowly rising at that point, which seemed to be a good thing. And the conditions that were keeping people out of work, they weren't so much, if you like, the rather entrenched chronic health conditions that could give you, obviously, health complications. But a lot of common musculoskeletal problems, which you thought ought to be able to be easily dealt with, and perhaps some of them dealt with through making workplace adjustments. And certainly a fit-for-work service, which was in my mind at that time, helping those, and common mental health problems such as anxiety, stress and depression. So they seem to be the things that you were hoping that could be addressed fairly quickly and quite easily, enabling people to return to the workplace. And then I did write a chapter on young people. What I missed then, and I regret that I missed it, I didn't see the rising of childhood obesity. I didn't really relate that to poverty and the growing inequalities in our country. And of course it was all relevant, as Marmot has subsequently pointed out. But the things that I recorded there, as we'll see, have definitely changed post-COVID. There was a lot of activity between 2005 and 20. Lots of reports, many of them actually really important reports, not just mine and David Frost's report, but the really important Borman review, which came out of my 2007 review, sadly at the cusp of a change in government, put on the shelf, which was really a great pity because it was about the health and well-being of the NHS staff, 1.3 million people. The really important Farmer and Stevenson report, mental health in the workplace, accepted by government but no government funding to accompany it. So all voluntary change, very difficult to bring about. And of course the Matthew Taylor report, which was about good work, the gig economy, etc. Again, excellent, excellent ideas, and policy making things in these reports. And of course the two Marmot reports, one from 2010, one from 2020. And as you all know, Michael didn't think we had made much progress. But just to really summarize what I think were the positives during that period, because I believe there were positives. People were working together. Government did accept the findings of reviews, often with inadequate resources to really get them onto a secure footing. Excellent stakeholder engagement over those years. It was quite difficult bringing some of my own kind along, but we eventually managed to do that. And then increased attention to mental health and musculoskeletal. All those things on this slide, I think, were good things. And there was better toolkits, guidance and training. And those toolkits were beginning to be evidence-based, and a government health and work unit established. And in that period from 2006 to 19, workforce participation rose by 3 million. But we shouldn't fool ourselves, that was mainly in the 50 plus, and it was not young people. And I think hidden beneath that was the fact that work participation by the young was reduced, and of course has reduced even further. Of course, the challenges, and it was ever thus, and they still exist today, political changes in government, a period of austerity from about 2011 onwards, a lack of sustainability of initiatives and consistency of delivery. I saw that happen to quite a few of my own recommendations. Of course, resistance to change. I recommended a research institute in my first review. They put out a call for applications. When the new government came in, they took away the money, so we never managed to get that. Training, challenges of how to do that at scale and significantly. And a slow and an insidious creep, which has become very important, of sustained chronic illness that is more related to lifestyle, our own lifestyle and our habits, and things that really do take us out of the workplace. And what has worried me has been this rise of a well-being wellness industry without really any evidence to support it, and decreased productivity. And just to emphasize that point, as you all know, our productivity has not been increasing in the last 15 years at work. Interestingly, economists gave health very little attention as being of importance in productivity. It was always on the technical side, but they didn't until recently think much about health. But this is just from a self-reported workplace survey, the annual survey, Britain's Healthiest Workplace Survey. That's just looking at some of the results, 2014 to 19. Their health-related productivity loss, they reported as having increased from 16 to 33 days per worker. So you needn't really go to work till the middle of February. I mean, that's what it really means. That's how much you have lost. And in those surveys, there was obviously more of it being driven by poor mental health, financial concerns, which of course leads to mental health. And just before sort of thinking, well, what has happened post-COVID, I don't know whether any of you have ever read this book, but it was rather a prophetic publication. Richard Donkin wrote for the Financial Times and is a columnist, but I enjoyed reading this book. And he said the history of the way we live and work is evolutionary rather than revolutionary, although that was going to change in COVID. But if you look at the list he had in his book of what he described migrations of practice, which he thought would happen over quite a long time, well, if you look at that list, quite a lot of them have been happening rather at speed. in the last 2 or 3 years. And he did point out that you didn't expect the migrations to go at the same speed in each sector, that industries and workplaces would vary. But this is what he wanted the agenda to look like for the future. He said home interchangeable with the office, give more people discretion and autonomy. How prophetic was all this? Insist on relationships being empathetic, emotional intelligence in management as well as our technical mastery, and promoting health and well-being with well-designed interventions and monitoring of outcomes, which we have certainly not done, which is one of the things that I will come back to. He didn't like the concept of retirement. I suppose I would have to agree with him on that. But then COVID came, and for me, I sort of divide its effects really into two big groups. There was a hastening of many of Donkin's predictions. There were some very positive things if we look at COVID. It wasn't, of course, COVID was very negative, but some of the things in the workplace were not necessarily negative. But I do think, and I suppose this is really one of the main messages of what I have to say, is there have been profound societal changes in the wrong direction. And Andy Haldane, as you know, for 30 years was at the Bank of England, the chief economist at the Bank of England, gave a fantastic lecture in November 2022 for the Health Foundation, an economist who now fully recognises the importance of health. And he said in that lecture, clear evidence, the first time since the Industrial Revolution, of poor health detracting from both growth and well-being. So I want to start by looking at the post-COVID workplace changes that I think have occurred. You may wish to add to this list. You could disagree with some of this list. Some of these were very rapid, so Donkin's predictions accelerated. And some of them, of course, negative, like staff shortages, record unfilled vacancies, line managers perhaps in the spotlight, not always for good reasons, but some very positive things have emerged. I've always thought occupational health has never had the attention it deserved. I wrote a lot about it in my 2007 report. I've tried to champion them since, but surely the pandemic and this post-pandemic period has showed us the need and the value of quality OH. When I had quite a bit to do with what was happening for the staff of the health, staff health and well-being in the NHS, we were scrabbling around to find sufficient good quality occupational health services. It made you realise how under-resourced occupational health was. But I don't want us to go backwards as we come out of the pandemic. I think this is a danger. We need a better central understanding in government of the commitment to and the need for occupational health input into strategic decision making. And I would much more like to see occupational health heard in the boardroom, in places where it can really make a difference. And of course, small and medium-sized companies need much better access to occupational health, and I was rather disappointed with what we got in the recent budget on this. I had hoped that the pandemic would have brought about a better recognition of occupational health and the need to certainly make it much more a national service. We tried very hard within NHS England. I was fortunate enough to chair their advisory group to get occupational health into their new framework, which is on this slide, which was a framework of creating a health and well-being culture. It seems ridiculous to think that it wasn't formally there before. It wasn't, but now as part of this wheel, the professional well-being support area is firmly where occupational health sits. And in this, the creation of this framework were many more important things, including managers and leaders, and data insights. And the whole intention had been that at a local level, NHS organisations could use this framework, which was published, I think, in about late 2019-20. And it would be a supporting framework with a lot of information behind it. And alongside it, there's been the growing OH programme, which is intended to develop a really highly professional service, mental health hubs, health and wellbeing guardians to sit on the board of an NHS trust, usually one of their non-executive directors. But I'm sure some of you know that it looks as if NHS England is going to devolve this to the ICSs. And for me, that's another very good example of a good piece of work, really with some very good evidence and work behind it, being outsourced before it's really strong enough to stand on its own 2 feet. So I think that is something that I really worry about, but that is, I think, the plan. And I'm sure the ICSs are so busy, can't see how they might have the capacity at the present time to take this on. Just one of the trends that I'm sure you've all been aware of is mental health. This was taken from an Unmind survey, 2021. This is HR professionals. And you can see there an increase in the need for investment in mental health. It really did go up the agenda, as so it should, because it's been quite obvious that it was necessary to do this. Which brings me to two slides, which I'm very pleased about. I was really pleased to see the Health and Safety Executive in November 2021 launching a campaign and saying that work-related stress and poor mental health was at risk of becoming a health and safety crisis. So making it, I hope, as important as physical health, and working with the charity Mind to really see if we could not get a really good campaign which would enable workplaces to give this the recognition that it really deserves. And I was even more pleased to see in your strategy for 2022 to 23 reduce work-related ill health with a specific focus on mental health and stress. So this has to be something good that has come out of the pandemic. But you can't really have health and well-being in the workplace if you have a poor workplace culture. And so often what I've seen is what's on this slide, where they stick health and well-being onto the side of the building. And when resources get really tight, they just knock it off, because it's not that which is required in regulation that would be required by HSC. This is a rather different kind, if you like, of health and well-being. And it's stuck on at the side, and then it gets knocked off. That is not what is needed. It needs to be in a firm base, just as embedded as other health and safety requirements are. And you can't do it without empowering leadership who are prepared to talk about it, capable middle managers, and I think a board engaged in hearing about and listening to about the health and well-being of its staff, just as much as it understands and listens to its financial well-being. And you can't just paper over the cracks. The mindfulness, the yoga classes, the fresh fruit and water are all nice, but they are papering over the cracks. And that, as this has become more important, we really shouldn't be doing that. This is really taken from the Institute of Employment Studies. They did quite a lot of work in COVID on the pivotal role of the line manager, and pointed out that it perhaps exposed the line manager in a way they'd never been exposed before, because it is very complex managing people who are working, well, then when they did this work, mainly at home, but of course now in a hybrid situation. And they were really pointing out that it possibly required for many managers more help and support. I hate the idea of sheep dip training, so I don't think you just send some off for a day of training and bring them back and say they're okay. But it did really highlight this pivotal role, and this slide is just taken from the work of a Swiss industrial psychologist who was very interested in the health and well-being of the manager themselves, and how well did an employer support their managers as opposed to just piling extra work on them. And he looked at the health and well-being of the manager, whether they were in good health. I've never had health problems, quite a lot of them didn't have that. I've never had physical problems. I've had psychological problems, and I've had both physical and psychological problems. And it perhaps comes as no surprise that those managers, although not so many of them in the survey, that had had both physical and mental health problems, had more unwell people working for them. Of course, that might have been a reciprocal relationship as well, and moved back the other way, and the health of the worker might, of course, affect the health of the manager. Another trend post-COVID has been that you saw, and I collected during COVID cuttings from our broadsheet papers and to see what trends were happening as we went through COVID. But more and more, you could see that health and well-being was being written about, and more people were saying, well, what works? How do I make it work? How do I establish the business case, and where are the toolkits to help me? Really wanting to make health a strategic boardroom priority. And of course, there's lots of unevidenced advice, and I just wanted to highlight this toolkit. It was an ESRC funded project out of the University of East Anglia. The research team excuse me, worked with other universities and around Europe, systematically reviewed many studies, and also analysed a lot of data. I'm so sorry. I think that's better. And I just wanted to bring this to your attention because it is evidence-based. It has got a toolkit, it's got a business calculator, it's got a network, and it's been very useful for people who didn't know where to start. And what they say is they're trying to really build sustainable change. And so it's not about just putting a few things in. Chris Whitty has talked to me lots of times about our lack of measurement of interventions in the health and well-being space. And he said, why don't we take the same scientific approach has been taken really by HSE. And he said many organizations are systematic and evidence-led about efficiency, productivity, and investment, are very unsystematic about health improvement. Now, Chris would like to see us do randomized controlled trials in the workplace. That is hard to achieve, really hard. to achieve, as I'm sure you all know. But I was heartened by the Institute of Employment Studies setting up last year a trials unit. It's 1 year old now. And it does try to bring together expertise from different research perspectives, sharing good practice, and really supporting any employer that wants to measure properly. And of course, it doesn't all have to be randomized controlled trials. There are other designs, and this is an area I really would like to see further developed. And then hybrid working, I'm not going to spend much time on this. This was taken from the broadsheets in 2021. We'll never return to the office, say 2/5 of staff. Could remote working spark a rise in workplace harassment, etc.? On the whole, thinking that we would all be working from home. This is from the news in 2023. Amazon calls staff back to office 3 days a week. I think the best we could say is there's no simple answer. It's a very lively debate, and certainly one size does not fit all. You can see arguments on both sides. And then finally, in my trends, that investment in digital infrastructure, which really moved at pace. Certainly you can see that, again, very much in the media. But a growing concern that perhaps do we have a workforce that is savvy enough in a digital way, and what about learning and development in this area? Donkin did not have a word to say about digital and investment in this space. So I think there are some very good things that have happened, and I do think employers really came up to the mark in those years before COVID in a very good way. But I think I really want to move now to the areas which I think are really very worrying. I think COVID fully exposed that relationship between the economy and health. COVID found a very fertile soil. It found us as a population obese, inactive, mentally not so very well, with great areas of deprivation and poverty. So that very poor soil in COVID also met an NHS which has become fragile. 600,000 people, as you know, have dropped out of work, 2/3 age 50 to 64, and mental health has diminished in almost all aspects. So I think COVID was almost a tipping point. Long-standing health issues had been there, but COVID fully exposed them. And I think history does suggest that health is important to the economy. It is a societal asset like the other capitals that we talk about. But if you read Michael Marmot's latest reviews and his writings, then we have a slowing of life expectancy, a rise in long-term sickness. Worryingly, a greatest rise is in the 16 to 24-year-olds. Mental health a large contributor. They are our workers of the future. And an accompanying rise in economic inactivity in our younger age group. This is from the survey that I mentioned earlier, Britain's Healthiest Workplace Survey. It has the warning note that, of course, it is self-reported by the employees, and also the employer fills in the survey. But an increase in poor physical health and an even bigger increase in mental health. So what have been the unwanted labour market changes? Increase in economic inactivity, and unlike other countries, we have not bounced back. In fact, our inactivity was rising. It may be plateauing a bit now. So is there a UK-specific factor? Driven, I think it's fair to say, by long-term sickness, even though people will argue about whether it can be explained by long COVID, can it be explained by retirement, can it be explained by caring? I think they've all got a part to play, but I think probably our increasing long-term sickness is the main thing. And home working, sadly, will not close the participation gap because long-term sickness is, on the whole, concentrated in low-paid on-site jobs. Just to put some visuals to this, I think when I wrote my report, we were in the 2004 to 2009 period. That was the first report. It looked to be going in the right direction, to be going down, but you can see that the rise was happening before we ever went into a period of the pandemic, and also in our young workers, it was happening again before the pandemic, as the brown and the sort of reddy brown line shows. And then just to add to all that, we've had inflation, war, energy crisis and a cost of living crisis. So we've had lots that have really made it much worse. So I went back yet again to my original review, and I said that improving health of the working age population is critically important. Well, we sadly haven't done that. I said it was important to secure higher economic growth and an increased social justice. And there were foundations that I wanted to see laid down. And there were things that I thought were really our principal objectives. And prevention of illness and promotion of health and well-being, early intervention. We tried to do that. We didn't implement it actually very well, and I don't consider that to have been a success. And we were making progress with those who were out of work, but again, that has rather changed during and after the pandemic. So what does this add up to? I think we'd have to say we haven't fulfilled the vision of 2005. But as I said, I do believe employers have tried. They've made an increasing response to the challenge. Could we ask more of them? Government over many years has made many attempts to respond, but often without giving it sufficient funds for long enough, or the delivery capacity and the perseverance, and therefore we have a smaller, less productive workforce. And we've had a large rise in the number of people out of work, and we've now got a record high at 2.53 million, and for the younger person, it's now over 1 million. And this was in the Times this weekend, and I just sort of thought, well, I'm going to make a slide of that. Welfare claimants will receive more than 100 billion this year from the state, 52% more than before the pandemic, with further increases expected. And this is largely explained by an increase in universal credit and personal and PIP to cover the expenses of the long-term sick. So is it because we're a nation in poor health, obese, insufficiently active, with poor mental health? Ill health starts in poverty. Levels of childhood poverty are high by international standards. We only give the same amount of money to a rich child as to a poor child. Being born into a lower income household can double the risk of obesity later, and obesity, of course, is related to many chronic illnesses. And our economic and financial fragility, particularly facing poorer and younger people, has that been one of the reasons for the increase in our poor mental health? And of course, this is all met now by a much more fragile healthcare system. So what would Thomas Ashton have thought about this? Well, he cared about his workers. He did care about the nation's prosperity. But Jane Bedford, in her biography, referred to the mills as their best in class in the country, suitably equipped with workforce well-being being paramount. This was a man who knew the value of the people who worked for him. He challenged the norm of his time, and he provided a safer and more socially just world for the people he valued so much. I suspect he'd be rather dismayed. I'm sure he would want to end child poverty and would have things to say about childhood obesity, which really starts with child poverty. So I'm not sure Thomas would be terribly pleased with where we are. So what are the solutions? And I just want to bring you, this is entirely from Andy Haldane. I heard him give the annual Health Foundation lecture, and he, as an economist, was arguing that you might put health into a lot of things other than where we have it at the moment. So this is the list of things where Andy would say you could strengthen the resilience of the UK healthcare systems, and therefore through that strengthen the health and well-being of people at work. And you can see they're pretty wide-ranging. He pointed out how well and how quickly we could get statistics on health during COVID. In fact, we had them daily, absolutely, in front of us. And why could that not be happening now? As he pointed out, as an economist, we stress test our financial systems to bits. Why did we not do the same for health? We did it during COVID. He remarked on the successes in Greater Manchester. He wanted the full implementation of the Dimbleby report, so the food standards, and putting health there. And he was very keen on putting the H into ESG, and you can see his full list there. And thinking about putting the H into ESG, I found something from the McKinsey Health Institute, which is really talking to the same, that particular point about health, much more into business. And they said, we believe that every institution on earth has a role to play in improving health literacy, adopting strategies, policies and resources to optimize health. And they pointed out that many of the drivers of health are outside our conventional healthcare matrix. And they said that every business could realize that investing in health could be an attractive economic activity, and that every employer should recognize the profound impact on the employee health and well-being of their experience at work. So they would certainly put the H into ESG. So I suppose we know the problems. I think many of the solutions are at least visible. Of course, they're complex and difficult, and we need to build sustainably now across many areas in a multi-pronged and multi-year strategy. But I believe we could be better than we are now. I think it's not that we don't know what could make a difference, it's just how do we ever get it, so that we can keep it at a sustainable level and we can develop it slowly over time to really be able to embed it. And of course, we can't forget just what a terrible jolt to the system COVID has been, but all that's happened afterwards. So thank you very much.
Carol, thank you so much. As always, really interesting, really insightful, and your perspective on this enormous challenge, I think, will give us an awful lot to think about. So, Neil and I will now seek some questions from the audience. I'm sure there are lots of burning issues that people want to raise, so it's over to you. Questions for Carol, please.
Or comments. Or solutions, even.
Shall I start, Carol? You've identified the issue of interventions and evaluations of interventions. We did some work with our Workplace Health Expert Committee a few years ago now, looking at the evidence around interventions, and they pointed out some of the things that you said around that complexity and how difficult it can be to get the right intervention strategy in place, given how difficult workplaces are to control in that sort of RCT kind of model. So what do you think the success criteria are for a successful evaluation of an intervention?
Well, I don't know the designs, for example, that IES, I mean, one would hope that there can be some relatively simple things that you could measure that would say whether if you put in an intervention, you are moving in the right direction. And it is enormously difficult, but the problem is you can't hand on heart say to any employer, if you really want to improve mental health of your workforce, these are the 3 things we believe, based on the evidence, will make a difference. And it is measuring something like presenteeism going to be helpful to you, because it is quite a good measure of mental health. I think just measuring absence, I don't think cuts it really. I don't know whether retention at work, but I do think maybe presenteeism would be something you could measure, but I don't think you can either inflict too many measurements. And of course it has the great potential to change, doesn't it, in a workplace where, you know, businesses can go up and down. There's so many factors. So this is not easy. I think the MRC for a period got interesting, then they gave up.
Yeah. It's so complex, isn't it? You say the intervention itself may change things, the evaluation may change things, the fact that you are paying attention to the workforce perhaps in ways that you weren't previously in itself could be an impact.
I don't know whether engagement of the workforce,
and then if I put the shoe on the other foot, because we're having these sort of conversations now within the context of our role as the regulator for workplace health and safety, and thinking about those egregious cases where clearly people haven't done sufficient. We're trying to think, well, what could we use to take a very high-profile prosecution for failure to manage workplace stress, leading to, you know, an outbreak, in inverted commas, of mental ill health? Because what would we enforce against from a standard perspective? Very hard.
Very hard.
Your views as to what you think we should be thinking about when it comes to getting those people who've clearly done a really bad job in the dock accountable for court.
That is tough.
Welcome to my world.
Well, I think I'm
I'll just dwell on that one.
Yeah.
Yes.
Our line into that is, how do you measure a good manager?
Yeah. You see the effects of a bad one. You see the effects. And so maybe you have to, maybe you measure their effect on other human But I do think, though, we often don't support the manager enough to be a good manager, and we don't really pay attention to their health and well-being, and too much of, I'll send you on a course. Well, what's the use? You know, then I've ticked my box. And it must be it's not a static situation, is it? Because we're all human beings. So, you know, you go to work some days and you're feeling pretty good. And you go to work other days. And I was in hospital medicine for many years. I perhaps shouldn't tell you this, but I will. But on the days I didn't feel good and I wasn't in a good place and I was in outpatients, I used to worry in case I'd missed something. You know, I'm not at my best today and I could miss something. I don't think they'd let me do it now on the grounds of efficiency. But what I used to do was say to Mrs. Smith, you know, I think I'll give you an appointment and see you in 10 days' time rather than 3 months. And I built in a sort of backstop for me, knowing on that day I wasn't as good as I could be. But that was a very personal way of coping with what is a normal. I mean, we all have ups and downs.
Can we press with the microphone down? I'm conscious that people perhaps can't hear the picture. There are roving mics, so we should be okay. Thanks, Alison.
Lovely, thank you. Okay, first of all, thank you very much for that. That was a really interesting talk. I just wanted to raise the point, something that's come up that I've talked about previously in terms of changing retirement age, and it's also come out of the COVID research that we've done, is this issue of regional differences in terms of health and well-being. And I wondered whether that was something that you'd come across, and also whether you had any suggestions for how that could maybe be addressed.
You mean general difference or differences post-COVID?
It's both. So, I mean, I've looked at life expectancy, for example, when looking at kind of planned retirement age changes, and there are very different life expectancies for different regional locations in the UK. But the COVID research that we did as part of the Protect programme also showed that there were regional differences in terms of exposure, and we know there are sectoral differences.
I mean, do you think it's partly because in much poorer areas of the country, if you like, the resilience in the population, the assets that each individual has?
I think that's a big part
and has grown up with. I mean, I've just been doing this work on drugs for the government and thinking about how do you prevent young people getting into the habit of taking drugs. You need something, certainly within the educational system and their family system, that builds the resilience that then when they're going to make choices, in a way, they've got something to help them. And from that work, I've really been exposed to the lack of resilience in this population. It's awful. And I imagine that is partly true in some of the, you know, in general in health and well-being. And I think when COVID came, the health of the population was very mixed, and for some people it hit extremely hard.
Yeah, I just wonder whether there should be maybe a policy approach to this. It's not something I see discussed much, this kind of regional differences. I think maybe it should be addressed a little bit more.
And there are huge regional differences.
Thank you.
I know Sheila does some fantastic work for us in our national core study for COVID, looking at what we would call the areas of enduring prevalence. And for me, one of the things that came out of that loud and clear, which picks up on what you said, I think, Carol, is that ability to make choices. So some people could make a choice to isolate, they could make a choice, you know, to use their ensuite bathroom, use the garden, whatever. Others didn't have that choice. So I think there's a real issue about, in some groups and in some work environments, the ability to make the choices that you should be making to protect your health are not available to you for all kinds of reasons.
Yeah, and poverty comes fairly large on that list.
So, there's a question.
Hi. My name's Cassandra Hodgkinson. I work at the University of Manchester. As a middle manager, I was quite interested in the comment that you made there about COVID exposing middle managers and their potential lack of being able to support their employees appropriately. And it made me reflect on the training provision that is there for managers in general to sufficiently support them in being able to have appropriate conversations with their staff, for their staff to feel empowered to have those conversations with them in the first place, and then knowing how to signpost them to the appropriate resources. And then you have the problem that, so I've had members of staff that have opened up to me about their mental health issues, and I've been able to support them in the workplace with that. But the difficulty comes with getting access to resources within the NHS. So it's not workplace-related issues that have caused a mental health issue. They had an existing mental health condition that, you know, obviously sometimes workplace things can compound that. But because they weren't able to get access to the appropriate resources through the NHS, their condition wasn't being controlled, and so then when you raise the issue about supporting people with stress-related conditions within the workplace and potential lawsuits coming from that, it makes it very complicated if the NHS isn't supporting people when they step forward asking for help. And then what are you supposed to do as a middle manager?
No,
Is just what went through my head thinking about middle managers, and then when you mentioned the legal side of it, it's a bit nerve-wracking.
I think I'm right in saying, I hope, that in this part of the country, you've been particularly short of some mental health support. Just because I've been interested in it through the addicted population and trying to see how you get support for them, and it really is a very overburdened, not sufficiently supported service. But that's true all around the country too. I agree. And it's no use just saying, well, we've got an EAP. I mean, it doesn't just... Yes, but that's not what you... I mean, it's beyond that, isn't it? It's how do you get really rapid, good mental health advice, and it's a gaping hole, if I'm honest.
Oh, hi there. Yeah, thank you for your talk. I thought it was absolutely, very, very interesting and hit a lot of the sort of the salient points. I'd just like to follow on for what was just said there. I'm an occupational physician, and something I was going to ask was just about whether there's currently any research or early indication as to, as was just mentioned, about the actual lack of productivity from people who are actually waiting care in the NHS. What I think was just mentioned there very well is I think probably not a day goes by currently where someone with a long-term condition who would benefit from treatment, and the example I thought was of someone, say, waiting a hip replacement. We know most people that have a hip replacement will return to work. They're waiting for 2-3 years. That's obviously a significant loss of potential work time. And then, again, as the example we just had, there is a limit to what managers can manage at work. And I wonder whether we're actually almost approaching a point where managers are being failed in that or employers are being failed in that respect by an NHS service which can't...
I mean, what I was hinting at, perhaps I didn't say it, but was that I thought sort of in the 2005-06, when more money was going into the health service, you could get attention, particularly for physical illnesses. I mean, very practical things like getting your diabetes under control, getting your hip replaced. I mean, you weren't on a long, long wait to see people get things done, which obviously the longer you're out of the workplace or, feeling you can no longer cope, for me, you become, it's not a very good word, but I don't know of a better one, you become deconditioned to work. And then it becomes much more frightening to go back into the workplace. I've talked to lots of people who, on long-term sickness, who can't face the thought of actually going back into that work environment because they don't feel generally fit, never mind the illness they've got. So it really worries me, the fragility of our health service now to support people who have got conditions that could easily be dealt with, and they could be back in the workplace. And compounding that will be anxiety and depression. I mean, I think that is quite a serious thing now, and that's why I think you're seeing this rise in long-term conditions. I think we're generally not very well fit as a nation, but we're not dealing with what people have got in a timely manner because we just don't have the resources to do it, and that's bound to affect the workplace.
Any other questions? Yes, please.
Thanks, Carol. It was an interesting talk. I'm just wondering if there's a greater role for employers to return to the Thomas Ashton days of philanthropy in this respect, of providing more well-being, mental health access, maybe to private healthcare, to expand their role outside of the workplace. So I guess in the way that some schools are doing now in terms of providing very basic support, particularly to poor families. So it was just whether maybe there's a role there, particularly for the richer employers, to fill the gap that we've got in terms of state provision.
Yes, and I don't know whether you know this. I hope I'm going to get these words right. There's an organisation, is it called... I want to say Business for Health, but it was founded by Jeff Filkin. It's now run by Tina Wood, with a large Legal and General and John Godfrey have been very supportive, but they talk about, you know, the three arms of a business supporting its own employers, the community, and their consumers. So you have this much bigger and much broader spread of interest in health and what an employer might do and might contribute. And that would be, I suppose, putting the H much more firmly into the ESG. And I do think that is a role. And you know, I also know some organisations, and this is where the extent of, I don't know much about it, but where investors are starting to really say to the people, the organisations they invest in, what is your investment in health per se? And I mean, it seems awful to say we expect employers to do more, but they're the most sort of visible, immediate people who could help, because I think we're still going to be on our waiting list for our new knees.
Martin.
To follow up on that, so Martin and Tonga from the University of Manchester. I think you mentioned early on something about SMEs. Now, I think most people in the UK are employed by SMEs. So some of the things that you talked about and the questions, I think, are probably very doable by, you know, large companies, large organizations. What do you see? What are the solutions in terms of SMEs? What are the possibilities?
Well, I had hoped, but it obviously didn't happen. But there's quite a lot of lobbying for it to happen, that the government would, in this budget, have been much more expansive about expanding occupational health in one way or another into SMEs, whether by incentivising or grants. I mean, you know, something has got to happen to make that possible for them. It's not just going to happen. I mean, I do think the supply chain, say taking the construction industry, you could imagine that the big guys could insist on the people they employ that not employing you unless in this contract you have agreed to look after your guys. Of course, government could do that in procurement, couldn't it? Because, again, so I think the supply chain, I think I'm right in saying Andy Street, the mayor in the West Midlands, has got several projects there. I'm I think partly with DWP, working at the SME level on mental health and musculoskeletal conditions in the workplace. And again, it is really incentivizing them, getting them going, getting them to see the value of it, and hoping then that they can pick it up afterwards. But I think we should still persist with the government on OH and SMEs. At least they put their foot in the water. And I think they mentioned occupational health about 6 times in his budget speech.
Question over here.
Hi, Richard Kirkham, Deputy Director of the Thomas Ashton Institute. On your third bullet point, you make the statement that we need to build sustainably across economic, financial, social and healthcare systems. But I wondered whether there was a missing word, which is justice. And the reason I ask that is, as a person who's inspected prisons over many years, I am becoming increasingly frustrated with asking ministers to address long-standing issues with mental health in custody. And I think the recent inspection of Cookham Wood Young Offender Institution, which described the prison essentially as inhumane, suggests to me that we've not really recognised the important role of a fair and tolerant justice system in addressing social inequality and improving healthcare for society. I just wonder what your thoughts are on that.
No, well, I from all the work I've been doing on drugs, I would absolutely agree with you. I mean, I think it's not just mental health in prison. I think it is, in fact, healthcare itself, and how that also moves on to aftercare. Because even if you improved it in prison, if you don't ensure that what's going to be supportive afterwards, I would accept that we should perhaps put that word in as well.
Excellent. Any final questions before I hand over to me?
No? Okay. Neil?
Thank you so much, and thank you for being such a great supporter for the philosophy of Thomas Ashton in everything that you've told us today. As directors of the Institute, Andrew and I are really grateful for you to underline our choice of Thomas Ashton as somebody we should take on as a role model for all our work. Can I take it from the way your talk has unfolded that what you're saying in essence is that the provision of the right to health, mental and physical at work is a causal effect and a driver for prosperity and economic growth? And if that's the case, how do we make government realise that and put it near the top of its agenda for the next budget?
Well, I think we all have to keep badgering them, but I do think any evidence that one can bring to them that fits in with where they're trying to go. I think to get government, any government, whatever colour, on your side, you somehow have to take what you have found to be the truth and the evidence and then frame it in a way that fits where they want to go. I hate to put it like that. I think that is the truth. So I could give you the most recent example. I did not ask government for money for drug addiction, for treatment and recovery, because it's the right moral thing to do for something that is a health issue that is treated so badly in this country. I said, if you do this, you will have less murder, you'll have less serious crime, and we'll have less people going to prison. We have a government that is interested in safety on our streets, less crime. And so by being able to show them the evidence that we would, and there is good evidence, that high quality treatment and prevention leads to less murder, less crime, less people in prison. I could then get money to actually do treatment and recovery. So is there a way of saying this is what we want to achieve and we have the evidence for it, but we can fit it in into your agenda? Surely now must be a good time with the economic inactivity. This is really top of the government's priorities, the shrinking labour market. It is something that, I mean, the budget was, well, not entirely, but very focused on returning people to work or enabling people to stay in work. So what is the argument and the material you can show them that says, okay, do this and you will get that and you will get more people back in and have a sort of some powerful allies on your side? And I think you do have to take quite a lot of this to number 10. I found my greatest allies were in number 10. And I think it's important to take it as high as you can go, would be my...
Yeah, thank you so much for that. It's been a real pleasure to hear you today and for framing that problem for the next Prime Minister so eloquently over the last hour. So it just remains for me to thank Dame Carol for her lecture tonight, and of course to Darren and Vicky and the Thomas Ashton team, but especially Helen, who's put all her efforts into organising this today. Can I ask you to thank all of those people, but especially Carol for her lecture tonight. And I wish you all a very good evening and hope that we'll see you again next academic year for the following Ashton lecture.